Do a quick introduction of our speaker today, Professor Vilimaga. He is a trained oncologist. He has completed his MD in radiotherapy from Bangalore University in the year 1982. He has received training in nuclear medicine from Baba Atomic Research Center, Mumbai. He was a clinical observer in international hospitals such as Norfolk Medical School, Virginia, USA, Arca University, California, US, Long Beach Memorial Hospital, US, Mount Sinai Hospital, Baltimore. He is a certified Cyber 9 trained person by accuracy in US. He is a fellow of International College of Surgeons and fellow of Indian College of Radiation Oncology. His special areas of interest are HDR brachytherapy, chemoradiation, and conformal radiotherapy, such as 3D CRT, IMRT, IGRT, and Cyber 9. He has received many awards for his work in the field of radiation oncology. Some of them are Professor P.K. Haldar Memorial Travel Fellowship of International College of Surgeons, and many more. His academic achievement is he is the professor of radiotherapy in M.S. Ramaya Medical College, affiliated to Rajiv Gandhi University. He is training postgraduate students in MD radiation oncology and a guide to PhD students. He is the medical director of HCG Group of Hospitals. So with this introduction, I'd like to call upon Dr. Vilimaga to give the presentation on cancer. Thank you, sir.
Good evening. Thank you very much for inviting me to share my thoughts on radiation. I know I'm not going to give you that kind of a very high thing on which you may not really like in life, such a the technical ones. But what is important for us to understand is to understand each other. What am I doing and what is the need of our patients? That's the background I keep it while talking about my today's about 20 minutes or 30 minutes presentation. In the HCG, we have evolved from 1989 till today, and this has three important phases to be told to people. The first one is in 1989, and when we started as a Bangalore Institute of Oncology. That's the one that you can see, the first one left hand. And in between, after 10 years, and it got converted to Bangalore Institute of Oncology, and by 2005 onwards, and it became Healthcare Global Enterprises Limited. So that's how it grew from time to time. And as far as the clinical scenario is concerned, way back in 1989, the kind of cases that we used to see, and today what we are seeing is definitely a change that we are seeing. If I take some of the diseases which are commonly seen, the one, take for example the cervix, which is commonly affected our women folk. We see quite an advanced state of CSF. Today also we do see advanced stages, there's no doubt about that, but early stages have started coming in. That's a good thing that we can really say, so that we have our cure rates are quite good. Take another site, which is again a common in female, is a breast. And we used to see advanced cases of a breast, and rarely really in the early cases about 23 or 25 years back. But today the early cases has come quite a lot, and we do see almost like a 30-40% of the times we do see early cases. And the incidence of the breast cancer, which used to be hardly about 10%, that has increased to 26%. Maybe the disease itself has the increased incidence, or the awareness among the people have increased. So people have started seeking the medical help. The third is a prostate, which used to be quite rare. Rarely we used to see, and today, it is almost 3 to 5% of the cases that we see among men are prostate cancer. And every year, this and days to go, because the longevity that we are now people are living, and certainly that's going to increase. The recurrent diseases, at one point of time we thought disease is over and we have conquered it, but it's not so. Disease comes back, and that is is very advanced cases that we used to see. But today, because of the with the help of the imaging modalities that we have, certain biochemical markers that we have, and we started seeing those cases in the early stage, and the long-term survivors, which used to be rare, and today we have seen a frequent or a common we see in our day-to-day practice. So there is a definitely shift that we can see and to a better way in the cancer management and how the patients really present to their doctors. Come to radiation proper. What is the the advancement that has really taken place over a period of time is starting from a two-dimensional planning, and which we used to do it, and we have gone into almost 3, 4, 5 times the better way, which technically called as a 3D, IMRT, IGRT, and as far as flattening. That is a very jargons, but I will tell you each one what their role are and how important for us and to having advanced in this science. What is most important point that we will have to remember today is, it is not the only one modality which has really helped. It's a multi-modality approach that we are going in for the management of the patient. Like chemoradiation. Today in a cancer of the cervix and a breast, we don't talk about radiation only or surgery only. We talk about chemoradiation. And also in the breast cancer, lung cancer. Most of the cancers are multi-modality treatment, and which is really helping. The future that we are really looking at is how well and we can really reduce the radiation morbidity, and that is where the proton therapy is coming to picture. The bottom, if you can see the way that we used to treat the patient was like a block, a monolithic block, and entire the area that we want, we used to treat it. And from that era, and we have gone to 2D planning. That means the area are sculpted out on some of the areas, and only we used to make a box and then treat. And from that onwards, and we have moved on to what's called a 3-dimensional. We know our human body is not just 2-dimensional; it's a 3-dimensional body. So we could able to get into that 3-dimensional picture with a CT scans or MRI, and now we can treat this with a 3-dimensional. Fourth, even that itself is not sufficient. Look, if I say I am 3-dimensional fine, but my nose is different, my eyes are different, my areas are different, and I have a lung, I have a heart, and each of these areas have a different way the radiation interacts. And now we can really, depending upon the area that we treat, we can modify the intensity of a radiation which impinges on those areas. That is where, and we have gone into the IMRT. In other words, the kind of a radiation which used to be very gross, and today it's really fine-tuned to the need of the patient to avoid the unnecessary radiation-induced morbidities. To tell about the one or two words, our hospital was started in 1989, and by 5 oncologists at that point of time. And our idea was basically to start our own clinic, and where we have a free hand to practice and the best care that we could offer to give at that point of time. But over a period of 23 years, the hospital has really grown beyond its leaps and bounds. Today we have about 23 centers all over India, and it's all networked. And you can see, starting from Delhi to Ranchi, and from down into the down south to Erode. So all those even the 3-tier cities have been covered, and now by our presence there in those areas with a very good radiotherapy machines which can really be monitored and treated. 89, this is the first cobalt machine we had at that point of time. To come in a private with a cobalt was really not known at that point of time, and this machine was dismantled in 2005, has treated almost 10,000 patients, and then we finally dismantled as the lifetime of the equipment got over. And What I was talking to you about the three-dimensional picture or the 2D was this. And if there is an area of the cervix that I want to treat, I used to mark on the human body, and this area used to get the treatment. And on the lateral side, and you can see this. So, and the breast also, this is how, and it used to be treated. And this is called as a two-dimensional way of treating. That means a two plane that we are seeing. But it had no little bit of drawbacks. One is in those days the skin sparing, salivary glands, and heart and lung were not really very easy to spare them, because we did not know at what depth the heart was lying and what's the quantum of the lung that was in the water. So that was the disadvantage of a two-dimensional picture. But on those days it's fine, and that was what was available and we could able to treat. Later, by 2000, and we have could able to acquire what's called the linear accelerator, which is an X-ray based machine, and that could really help us to give a very high dose of radiation, and with sometimes it could be two-dimensional, but as we really progress and things got really changed. What I'm saying is today is you can see the way that we moved, and from the Cobalt era to LINAC era. Today, any of the equipment that's bought, be it in government sector or in the private sector, people are now going for LINAC, knowing fully well there are many advantages one can have when using a linear accelerator machine for treatment of the patients. The question, if it's asked, then why did you use cobalt in those days? Yes, in those days it was true, and that was the only thing that was available. So therefore, and we could able to go and use them. The way the 2D conventional treatment used to be there is, this is the way it used to treat. But if you see, there used to be a mark, and the entire breast used to be treated, and the lung and the heart, and also used to get the radiation, which is not necessarily to be given. And particularly in the case of the breast, because the artery, and if it coronal artery, if it gets involved, the question of cardiac attack and used to be higher. So therefore, we had really the drawback of using a 2D treatment for conventional radiation to the breast. But we did not have any big problem on a skin sparing effect or a bone sparing, which was a problem of the 1940s or 50s. Luckily, with the cobalt, those problems are sorted out. But what we really wanted was a good therapeutic index in between what we are giving radiation and what is the outcome of that. And that we could able to achieve by using a three-dimensional radiation. With this, what we can do, take a CT slices at every point. Now we know, and if this area is getting the higher radiation, this can be blocked and give a radiation only to the breast area. So in that way, and one can avoid the radiation to unnecessarily, and which used to be given to various places. That is possible. If you see the left and top, there are the multiple leaves, we call it collimators. And whenever you need, each one can be pulled down or up, depending upon the reason, and only that area of the pole and gets the radiation. So that is the way, and we can avoid the radiation to the unwanted area, and which used to get the radiation. And the planning system, that means what I'm saying about planning is, when we say that I want to deliver certain quantum of radiation to the patient, how do I really do it? Is it really going or not? I had no idea, and I used to prescribe and hoping that it really works. But now, with the availability of certain dosimetry and in various parts of the body, and the computer can now calculate and tell us, look, this is the area it's getting so much of a radiation, this area this is how much of a radiation. So I'm now quantifying in my in the treatment policy how much of a radiation that I want to give. Then came an era what is called as intensity modulated radiotherapy. As I said, not all areas requires the same amount of radiation, and also certain areas has to be avoided. For example, if a spinal cord is here, certainly I don't want a radiation to go here. But how do I do that if a radiation it travels in a straight line? So how do I bend the radiation to see that it encompasses the rest of the vertebrae but not the spinal cord? That is possible, and with the use of intensity modulated radiation, which gives the radiation from a different areas. You can see the different areas, different angles. Now radiation can enter the body in from various angles and see and where the spinal cord comes into picture, and it reduces the quantum of radiation. So intensity of the radiation that enters to that area is now reduced. So with the result, when you get the overall picture, and you see as if the whole radiation is really bent to avoid a spinal cord. That is the advantage of what is called intensity modulated radiation. Now why I'm saying is, practice many times when the patient comes back and tells you, so look, doctor is advising this, IMRT, what to do. And at least you should really know what is meant by intensity modulated radiation and why it is used and for what purpose it's being used. Then again, what happens in our body, I told you it's a three-dimensional structure that we have. Really speaking, it's not just three-dimensional, it's a four-dimensional. Because over a period of time, and we do breathe, our internal organs also move. So that motion also has to be taken into consideration while treating the patient. That is what happens unless we really track that area of the movement. Like if it's a lung cancer is there, and when the patient is breathing and the tumor is also breathing. Now that has to be tracked and while giving radiation. Otherwise, I'll be giving a radiation to an area which doesn't contain the tumor, and I may miss the tumor which really has the radiation, which goes out of the field. So every time only if I track the tumor where it is, and it's possible to do that. That is called as the image guided radiotherapy. That means just before I give the radiation, I image the patient, I know where exactly the tumor is, and that by a fraction of a second it hits that area. So, and every time this information is fed onto the machine, and that automatically changes if it is required, and now treats the patient. This is called the IGRT, or image guided radiotherapy. This is a machine, and we have for image guided radiotherapy in our hospital. This is a CT scan. It's like our regular CT scan. And before the patient is put on the machine, and the table turns and it goes inside and takes a picture of the whatever the area is required, and that picture comes into the control console, and now it is seen whether the doctor and prescribed and now the patient is lying, is it matching together, and that will be tested, and if it is matching, fine. If it is not, it can be adjusted right there, and then again table goes back, and this linear accelerator starts treating the patient. So therefore, every time, and when you want to use it, you can use a linear accelerator. It's available in the same room, or there's what is called the EPID, which takes the X-rays right here. So when you know that the difference is not much, every day you're treating, patient is okay, and the images are okay, then we don't use a CT. At that time we use an image, the EPID, or the what is called electronic portal imaging. So in other words, now we are sure that what I'm doing, what is prescribed, is going to the patient's body in the right way, in the right direction, to the point that is intended to. Then came the era of having a PET scan. This is a positive emission tomography, that what biological information that it gives is whether the tumor is really active, and biologically how how far it is active, and that information is given, which is very important for us to know how well we can encompass the tumor. You can just see here, and this is area that certainly we want to treat. And here, if you see just a CT, I may not able to know where exactly the tumor is. I would have given a bigger margin to treat, and if I know now this is the only area that I have to treat, now I can focus my attention to only that area. Not only that, in that area I can give a more radiation what is required, and which contains a more of a cancerous cell. So that is the advantage that we have, and in using the PET CT for treating the patients with radiation. Today in our hospital we have developed the newer molecules, and which are quite few are very interesting and unique. Like for prostate, a choline PET is regularly what we do is for 18 AFDG, but a choline is very specific to prostate. then the brain is again methionine, and endocrine is DOTA. So these are the different molecules that are used for a specific purpose of the disease that we want. That will be really quite helpful when we are treating that kind of a patient and which requires the radiation. In 208, we also felt we should move further. The meaning of that is the emphasis was stereotactic radiotherapy is started coming into India in a very big way. And as all of you know, that Professor Lexel is the first one who really ventured out to give us stereotactic radiotherapy using the cobalt machine. And what it really does is it focuses the radiation, and it is a cobalt actually, and from various areas to the target point that is wanted. So with the result, which we used to do it in almost 6 to 7 weeks of treatment, now it is reduced to 1 to 2 weeks of treatment. And many times within 1 week itself, one can really complete treatment of those specific areas. This has started with the head, and because he is a neurosurgeon, he was interested in that. Now it has been extended to other parts of the body also.
Excuse me, so what is stereotactic?
It is the focusing of the radiation from a different angle to the point of interest, 3-dimensionally. Every time when it's radiation is given and it hits only that area, that is the called stereotactic radiotherapy, stereotaxy, they call it. To do this job, and what we have the machine is called as a cyber knife. Actually, cyber knife is a word that came up from two contexts. One is cyber means very accurate, so that is what it is, and knife is borrowed from surgeons. So what surgeon does and using the knife, and the same thing can be done very accurately using this machine. So that is the reason how the name of the cyber knife came up. And it does a stereotactic radiation to the patient. And the very important one to know here is it reduces the treatment margins. That means today we do not want to treat the area which is bigger than what the tumor requires, and it increases the dose. See, earlier we could not have gone beyond the unit of 60. But today we can even go to 70, 80 gray of a unit of radiation, which is a curative dose for the patient. And that is possible because now we are not irradiating the normal tissue. And also to reduce the complication. When the normal tissues are not irradiated, complications rates are obviously very, very low. Internally, we can target this tissue by, as I said, if it's a moving organ, there are various methods and where we can really gauge the respiration, how well the lung is moving and how fast it is moving, and gauge it and treat it only at that point of time and to the area that is required. And this is called the external gating, and there's internal gating, and we put a fiducia. So this is internal gating. What we do is we put the gold fiducias right into the area that is required. Actually, this is the head of pancreas, and we have put 3 gold fiducias. Now the machine, every time when the machine gives the radiation, now it tracks these 3 gold fiducias, and when they are matching, and it gives the radiation. So every time when it moves and then gives the radiation, we know exactly to the point which area it is receiving. This is called the internal, internal placement of the fiducias and tracking of the tumor. In SBRT is another word that's being coined. When it's used for the head, SRS and SRT, that is stereotactic radiotherapy, there we call it. When it's used for the body, it's called stereotactic body radiotherapy. It's all the same, the areas are different, that's all. So, which is useful for the hepatobiliary diseases, and particularly in re-irradiation when you want, and one can really use this machine. 1 or 2 examples I would like to show you, and this is the case of CF breast with the 2 metastatic deposits in the brain. So now we know we can really target only this area and only this area and treat it. There's no problem at all, and the rest of the brain is spared. Earlier, what we used to do is entire brain used to be treated, and because we know patient may not live longer and with the brain metastasis, So therefore, it's okay, and we can go ahead and treat. Today we know, even with the brain metastasis, patients are living longer, and you cannot afford to give them any morbidity related to brain. So, which is possible, and using these gadgets. And this is a case of a meningioma, and right deep inside, and you can see the the lesion here, and the radiation enters through different portals. And in this particular case, and it is coming from almost 145. These areas that you are seeing is an area where the radiation enters the body. And this is such things are 145 directions, and it enters the body. The reason why it does is it avoids the eye, it avoids other part of the body, and it can only treat this area and what is required. So which earlier, if I in our regular machine, I used to use it either one from one side or two sides, at best maybe four. And when I went into IMRT, it used to be for 7, 8 sides. It is possible to turn the machine and treat it. But with this machine, now actually the combination can go to 1,200 positions. I can keep the machine, and it can rotate and treat the patients. So in other words, the versatility of the machine is such, and we can easily avoid which is avoidable area, as what we are concerned. We call it the critical organ. And I know acoustic schwannoma. It's a bilateral acoustic schwannoma. So small and tiny, and how well we can encompass this with the radiation, you can see. And yet, the brain can be avoided. So with the or completely avoiding the eyes. So the idea and being these areas can be very accurately. When I say accurately, I mean the sub-millimeter level accuracy, like a 0.02 millimeters accuracy. So that is the accuracy, and with which now, and we can really irradiate these areas and to know where exactly we are treating. And this is the recurrent GPMs. Earlier, if a GPM recurs, and we never used to treat them, that's the end of the story, because we cannot do anything further. Today, with the availability of the radiation, we know even if it recurs, and there's a hope and giving a radiation to that area. And many times, surgeons do attempt to resect it, but this is a much simpler way, and when we can really give a radiation to those areas. And in this particular case, and if I can tell you, 161 beams are used. Now you can see the areas of entry of the radiation from 161 directions. And if you see the normal area, this is not seen very clearly here, and this is the area which is radiation to the tumor, what is given, and the normal tissue is here. In other words, there is a big gap between the normal and the abnormal, and how the radiation can be really spread and can avoid the normal tissues to a very much acceptable level. So also, and if you see the head of the pancreas, and the pancreas is yet another area which is very, very difficult even for a surgeon to operate it, and to have such a very morbid procedure. And with this, not that we are going to cure the pancreatic cancer I'm talking about, but the same, the kind of a result that the surgeon can give, and one can give with the radiation, because now we can focus onto the pancreatic head out of the body, avoiding what is most important is both the kidneys and the liver, which used to be a very big deterrent, and for us in earlier days where there was no way we could have done that. So in that way, the stereotactic body radiotherapy and using the cyberknife has helped us to treat these areas. This is our team in our hospital, and which in the middle that you can see Professor John Adler, and he's a neurosurgeon, and he's the one who actually invented a cyberknife. And this is our team in our hospital, which we treat the patients. And so far, we have treated more than 1,000 patients and are using cyberknife. I'll now move on to the next generation of the machines, which is not really competitive to what I said as a cyberknife. This is in a different area how it can really work. What is today is called as a flattening free filter or triple F machine. And you must have heard of a TrueBeam or Agility or Axis. These are the different companies that manufacture. The idea of that is the general Linac used to give a radiation dose of only 2000 mu. It's a unit, 2000. Now we can even go up to 10 times. meaning of that to the patient is, if I'm treating a patient and with 15 minutes time on the machine, now I can do the same job in 1.5 minutes. So to that extent, particularly in the pediatrics patients, it's very useful, and they need not have to be lying down for 15 minutes, not that easy at all. And now work gets over and within 1.5 minutes. So in that way, very, very high dose of radiation with precision, and one can give, and that is the today we are using in quite a few places with the platinum free the radiotherapy. Now I will just take you to the another area of radiation. That's the brachytherapy. Now, whatever that I said today up till now is external. That means we are giving the radiation from outside. Beta cyanide, beta linac, beta cobalt, it's all given from outside at a distance. Usually distance used to be 100 centimeters. Now I am showing you this is a brachytherapy, and the reason why I have put a telephone is this. The inventor of a brachytherapy is not a doctor. He was Alexander Graham Bell, and who has nothing to do with the medicine, and he is the one who gave idea to the doctors how a brachytherapy or equipment or the radiation can be used. So this is my very favorite point. I always tell them, always please keep your eyes open. It is not the doctors who are helping the patient. It's so many other people are really at it, and they are really care for the patient. And in radiation, more so, all our physicists are the ones who really contribute to the development of radiation, and doctors use them. And in this, the brachy is from the nearest point, and when we can really give a radiation, many times isotopes are put inside the body, and then the radiation is given. That's called as a brachytherapy. In this, there are areas where we can give it in the cavity, like the cervix. We can keep the radioactive isotope inside the vagina and uterus and treat, or it could be in a breast. And when we really pierce these needles and then put a radioactive isotope and inside the tumor directly. In other words, and these are done as in the operation theater, and with these equipments being kept there, verified, and then the treatment goes on. Very short period of treatment, and so therefore this is quite a popular way of treating the patients with radiation. It's also useful when we want to give extra radiation, what we call a boost radiation to the patient, and whenever required. And what is now is the future? Have we really come to the dead end of the radiation? Really? Not really. Science is always a moving target. There's always something in the future to look for. What we are looking for is actually a proton beam therapy. If I have shown you the graph, I said this graph is really wide, and between the normal tissue and the abnormal, even the small one which is there is detrimental to particularly to the pediatric the patients. Even that we want to avoid. And that is possible if you are using a certain type of a radiation which is emitted by the proton and protons, and that will deposit all the energy and only in the tumor tissue, and which we have identified by the treatment, and that is where the treatment is going to be. That is our future, and how we are really looking at it. And we are planning for one, and probably it's going to be in Delhi, and in India as of today we don't have this proton therapy unit. The other areas of the applications of radiation is using the radiation with hyperthermia, because it is said when the body temperature or the tumor temperature is a little higher, around 42 degree or to 45 degree, the with radiation it responds better. So using that is also enough. The third one is to know the biological efficiency of the tumor. If you know earlier how the tumor is really active, our radiation dose can vary, and we can really give a differential radiation into the point, and also over a period of time when the radiation will shrink the tumor, and we can adopt our radiation to that, what is called biologically adopted radiotherapy. These are our future radiotherapy and the progress that is taking place. And of course, the paraoperative, directly one can place the radiotherapy, radiation, radioactive isotopes. They are using the soft X-rays. One can read. These are the few areas which we can really see how a radiation can be used, in various areas. We and from HCG and luckily could able to really adapt to the changing and advancement in oncology. Particularly, I'm talking about radiation because I work in a radiation department. From 89 to till today, and from the COVID era, and we were able to go on up to a triple F or cyberknife and whatnot. So that's the way that we are looking for. Probably in future when a proton comes, and we'll be much more happier. Thank you very much for your patient hearing. And
Questions?
happy for this question.
Questions?
This cyberknife for surgery, who decides what has to be done and what are the indications for cyberknife?
Yeah. The decision is done by a group of the doctors who are involved. The first one is if is a referring person or a surgeon who is involved in the patient care primarily, who knows about the case, and we involve them in a decision making. The second one is the radiation oncologist, the primary oncologist, and who knows how much of a radiation to be given to that area, and he decides. Is a second component. Third is a diagnostic radiologist or a nuclear medicine specialist, and who gets involved, particularly helps us in a tumor delineation, what area to be treated, and he helps us in a tumor delineation. Is a third person who gets involved. Apart from background groups of medical physicists or technologists, apart from that, these are the three groups which gets involved in this decision making. The second question for you is what are the areas that indicated. If you take the the brain, is a metastatic deposits and glioblastoma multiforme and benign conditions. I have shown you schwannomas, meningiomas, all those the AV malformations can be treated. And in the body, lung tumors, and particularly today the stage 1 and 2, and things can be done with only cyberknife and intra-abdominally. And if you come pancreatic tumors, liver metastasis, and abdominal lymph nodes, paralytic lymph nodes, and recurrent one particularly, one can be taken care of. And in pelvis, recurrent disease one can really treat, and in the spine, and particularly when you want to treat sparing the spine, then nearer to that, and if there are any lesions, and one can take cyberknife treatment for it. So these are the various indications that we have as for cyberknife is concerned.
What is the percentage of surgeries that are reduced with the advent of cyberknife?
In fact, to tell you, I don't think the surgeries have reduced in our hospital at all. It has. I put it. It is redefined. That's why I called it as redefined the role of surgeons today. Okay? We do need their help here. At the moment they know, instead of going for a Whipple operation, and they know that even if they can do away with the radiation, and they would rather prefer that. So therefore, and it's primarily a surgeon accepting it. Yes, they can be part of they are part of the treatment in their decision making, and they will give it to me. Per se, I don't think the numbers have come down very much. Their role has been redefined. I put it that way. The same thing in what's happening in a breast surgery. Earlier, they used to do a radical mastectomy, or supraradical mastectomy. Today, you don't see that at all. It has come to lumpectomy, and in fact, going further, the work going on is, if I have the lump, take a true cut biopsy, because that is required for various other purpose, and thereafter there is no need to take even the lumpectomy. Give a stereotactic radiation only to that area, and only to that area, and be done with that, because you don't require surgery at all. So in other words, it is getting redefined in those areas. Yeah.
And how many centers do we have in Bangalore as of now?
Cyberknife is only one, our center in Bangalore. These are very expensive. In fact, that's why whenever we talk to them, I said, share the resources. It is not that your patient will be taken away from them. Patient really requires, and share it. There's nothing that when once it's over, it comes back to you for. It's not only cyberknife at the end of the treatment. Your patient requires so many other treatment for that comes back to you. Otherwise, this equipment cost us about 25 crores, plus the space and the housing of that takes away another 5 crores. 30 crores. Where do you want to be? Spend so much for that? Absolutely, there's no need. we should have the best things to share the resources.
Share the resources means among the hospitals.
Yeah, among the hospital. This is what but with the doctors it's very difficult to but now slowly they have understood. That now we are getting quite a good referral from them. That's how we could able to really cross 1,000 patients in this nation within 3 years.
So is there in different settings for this thing? How many times he has to go for?
Three times, 3 to 5 times, 3 to 5 times. Benign tumors mostly one. Within the one fraction itself gets over, and if it's a metastatic deposit, it's 3 times.
I've heard like the patient is going for he has to undergo some 3 more cycles of the chemotherapy.
Chemotherapy is different. Yeah.
Radiotherapy.
No, I'm talking about radiotherapy. Radiotherapy using CyberKnife is only 1 to 3 to 5 times. So depending.
Why don't we
on
use for all the cancers radiotherapy than going for chemotherapy? Is there any advantage?
No. One thing I will tell you, CyberKnife is not a panacea for everything. Please let's understand very clearly. It is not a panacea. Oh, every cancer is there I can treat, and with the CyberKnife I will do that. It is not. It has a specific, the indications. For example, I can give you glioblastoma multiforme. It's a disease. It invades, pervades into the into the brain. There, if I say that I will give a CyberKnife, I'm a fool. I will have to use IG-RT machine for that, shrink the tumor and give the peripheral margins and treat that disease. After that, at the end of the treatment, at the last 2 fractions, and give it the CyberKnife. And that area which requires a very high dose of radiation, there it is really indicated. For example, if I want to treat a head and neck malignancy, it's a pyriform fossa lesion, and there's no room for for CyberKnife. The ideal is our IG-RT machine. So therefore, we must really know what machine to be used and for what purpose. Now, I only said, and that's why I said, not necessary that every institute should have it. It's not necessary, because the indications here is far and few, and only those indications, and you can use it. I have shown you another schwannoma. The surgery is so difficult. The expert surgeon, you will certainly do it, but still the morbidity and difficulty with which if you really ask, it's too much. It's so easy, and with CyberKnife. If you really want you witness, you will really appreciate that. It's the issue is so. And it has been really brought down the morbidity to that extent.
So by giving one more thing, by giving the radiation in different dimensions, you reduce the dosage to the skin and other structure in that area. So it summates the giving from so many directions is only to summate to the particular this thing, or is it
to focus to one area, but from the other area, what it gives is it really dilutes the radiation dosage
to the other normal structures.
Other areas. We it dilutes the other area, and also these are very narrow, the radiation portals. Have shown you 160 fine, and these are very almost like a 1 millimeter or even less than a millimeter the openings, and in that way it enters. So only that area gets the radiation. Second time when it goes, it doesn't go through the same area. It's a different area. So there's
all areas goes in the same
to the same point.
Same point.
To the same point it goes.
Simultaneously.
Yes, it goes. That's all.
Have you seen any CT-induced radiation injury in your practice? So
I haven't seen so far.
Abroad or in India?
At least to my knowledge, no, not to my knowledge. But we have seen the radiation-induced, particularly with IMRT, we have seen. That is, if you are not careful, that's why I said, when we embarked onto this, we did not go for IMRT right away. We had an experience in 2003 with a plain LINAC. Then we went one step ahead after 2 years, by having a 3D CRT. After experiencing that 2 years later, 2005, we entered into IMRT. We did not really, enter straight away, into the IMRT. And even today, all our IMRT has been done in the rest of the centers in our HCG network hospital. Every information like what you have a teleradiology, the planning is done in our hospital centrally here. The central physics we have department. All plannings are done here, and the quality control is done here and executed in those places. Ranchi we have IMRT machine. You can't get the high-end physicist or a radiation oncologist there. So therefore, even if you have middle class and a middle level, and that is sufficient for us because the quality control is done here. And he cannot make a mistake because they're all computerized. So that is the advantage of